I am Dr. Francis Williams, the moderator for this morning's session. Our theme this year is resilience in healthcare delivery. We are extremely fortunate this morning to have two top-rated keynote speakers along with three exciting recent graduate presentations. So let us get started. Our first speaker is Dr. Glenn Jones. Dr. Glenn Wayne Jones is a clinical epidemiologist and radiation oncologist, practicing in the Bahamas and in the Eastern Caribbean. Many of his formal academic contributions are available at researchgate.net. He is affiliated with the University of Toronto and UWI. His primary research theme is to improve, and transform the value of healthcare through studies and analytics that focus on optimizing causal relations through bigger clinical data sets. His passions include teaching research methods, data management and biostatistics, and expanding psychosocial and supportive care to address patient distress. He enjoys using data for analysis and for simulations. He is a scientific officer for a number of randomized trials conducted by the International Atomic Energy Agency of the United Nations in cancers of the esophagus, breast, cervix, rectum, and lung. Dr. Jones is an internationally recognized expert in mycosis fungoides, a cutaneous T-cell lymphoma. As a teacher, he has mentored over 100 students and staff in over 50 research projects. His chapter in the 2013 WHO Handbook for Cancer Research in Africa encourages all clinical students and staff to engage in clinically oriented research using smart designs to capture data efficiently and accurately in the context of daily clinical work. Our keynote speaker, Dr. Jones, will be presenting at the interface of clinical medicine and national resiliency, a preliminary scoping review. Dr. Jones.
Okay, great, thank you. Thank you for that nice introduction. The purpose of today's presentation is to think a little bit about how clinical medicine and national resilience might actually fit together. And so the gist of this is really a preliminary scoping review, and I have some co-authors as listed here. Now, learning objectives are to know the definition of resilience for health systems and nations, to understand the contours of the literature from the scoping review, to reflect on some potential determinants of resilience, including medical care, healthcare, and that should be public health. So what is the challenge? Well, there's a number of exposures that our systems and societies could experience, and these are considered to be shocks. And I've listed them there, a number of them, some of which happen in different parts of the world. And these cause problems both for society, but also for the delivery of healthcare. So having sustainable healthcare delivery and reorganization in a situation such as COVID-19, as we've just seen, is a significant thing that we need to pay attention to. Now, what are the characteristics of shocks? Well, they're acute typically, although some can be chronic as they play out. There are perhaps four phases: preparedness, onset and alert, impact and management, and then recovery and learning. Shocks do unfold, evolve, and extend in different ways, and they may repeat, such as repeated hurricanes. They may overlap, or they may be concurrent with polycrises. If we compare this to stresses and strains, such as an aging population, impact of obesity, more drug abuse, those are stressors, but they're not really at the level of shocks, not at least in the short term. How do we respond to shocks? Well, historically, we've been fairly reactive. So a disaster has generally meant that local responses are insufficient and outside resources have to be brought to bear, such as a major famine, for example. The first response may be relief, food, water, some staffing, NGO activity, but not necessarily reconfiguration or transformation of the system, because the intent is to return to the prior condition, what we call in medicine homeostasis. There are steps towards doing better, however. There was some focus in the 1990s and subsequently with the development goals on sustainability, including strengthening the healthcare system and leading it towards greater integration, both internally as well as connecting to society and governance. However, the effects of a shock may be nonlinear, and we might not be able to return to the starting point. This is what we call allostasis. With reconfiguration and even transformation. Now there's an emphasis on resilience, so we have to come up with the definition of that and start to understand it in a better way. So the scoping review was done to find a number of articles, but there's no perfect search strategy for this one because of the rapidly expanding literature and terminological heterogeneities. This was electronic, but I did look for some gray literature, looked at similar articles and citations, and then decided if the articles are relevant, such as, does it include both health and national resilience in the same article? Or are there just articles about health or national resilience rather than at the interface? So text was extracted, collected towards saturation for synthesis that was thematic and narrative. So there's a number of questions that this literature addresses. I'm going to just talk about 5 that are in bold or listed here more clearly. The definition, framework, strategies, and principles, the appraisal of the evidence in support of these, research questions, and then the interface question. So in terms of a definition, many have been used in different disciplines. And just as one example, one scoping review listed 45, and they all had different terms, senses, and reference. So the definition is not uniform in the literature. The WHO 2020 Policy Brief 36 gives this definition, which is not unreasonable: the ability to prepare for and manage, that's absorb, adapt, and transform, and learn from shocks, which are sudden and extreme change. Now, additions could be made to this, such as it's a dynamic process, it's multidimensional, and the WHO has also called resilience a competence. Now, just to keep this clear, the ego resilience in a person for a non-shock exposure is a term that we're not referring to. And resilient as an outcome, a demonstrated outcome, which is more coping, but not being is not resilience, is also not under the purview of this definition. Now, the second question is, are there frameworks, strategies, and principles that the literature provides us, which might start to define the content that goes under that definition? So the literature provides dozens of lists of variously labeled functions, areas, frameworks, or strategies. Some are even principles. And they're not that specific or actionable, certainly not at the level of more detailed planning. So they're relatively high level strategic views of what components might be within what we would call resilience. A few examples of how these are high level is what I'll just now demonstrate. These aren't necessarily the best. I just picked 2 because they demonstrate 2 different themes. The first one being the more common type presentation, and the second one being a little less common to find in the literature. So the first example is this summary literature review on low and middle income countries by Grimm 2022. And it builds on a former paper in 2015 or earlier by Crook on 5 influential elements to generate a total of 10 themes. And as you can see, they're just listed here. So integrating internally and with the community, foresight to planning, preparedness, such as having rules, awareness because you've got informatics available, diverse, which doesn't mean diversity in the current sense of the term, but it means meeting a range of needs and leveraging a range of resources. So a network or a flux or nexus of how things can meet the demands by improving or reorganizing the supply. self-regulating to meet needs, adaptive allocations, realigning relationships, change management that helps steer a response to a shock, and government will and motivation over the time of the crisis. So you can see that these are fairly high level, and it's a little unclear as to exactly what one would do in response to this if you're trying to develop a plan. The second example is this one by Birnbaum in 2015, and it just lists these 14 steps. And you can see here that this is a more linear process to review your situation, prioritize hazards, look at your current status, identify your needs, and then start to plan to see if you can bring an intervention in that would improve your resilience. So there's some additional ideas after the saturation of those kinds of concepts, and there's probably 40 or 50 of those in the literature. Sometimes only 3 or 4 are presented. Sometimes it's as many as 14 to 20 with many subdivisions inside the text within each of those kind of areas. But there are some additional ones that came out, such as managing cross-scale dynamics and feedback, adding learning and adjusting to long-term changes. And then there was this 3+2 dimensions model that was information systems for decision-making, funding and financing, health workforce, but it does not focus on the resiliency of the health workforce necessarily, nor on key drivers in that that actually build resilience. So it's more about who plans, who implements, and how is it done. And then there's 2 cross-cutting issues such as governance and values, and this issue of integration. So what else seems relevant? Well, in the literature, there were quite a number of other things that I pulled together, and I just cited where they're from. Everyday resilience, which is building everyday resilience so that when you get a shock, you're actually better capable of doing the work needed to respond. Having a balance between centralized and decentralized approaches. Having mindfulness, values, making sense, and perceptions are important for the workforce and for individuals in society when there's a shock. And then social capital and networks, culture, community, and the legitimacy of institutions. So these were also listed as relevant. So you can see that if you started to take all of this literature and put down all of these terms and reconfigure them into a kind of a model, you might have 50 or 60 terms. And it might be rather difficult to think about how these interact. And so you could develop a model that's an analog model, a digital model, or you maybe could use artificial intelligence at some point to assist in a resiliency strategy. So what is the evidence for all of these things? Well, there's actually very little empirical evidence. There's a few case reports such as Ebola responses in Africa, earthquake responses, tsunami, but they're just a few types of shocks. Studies typically look at one element and not the whole of a response. So in other words, you might be interested in 50 odd elements, but these are not all covered in these case reports. And where there are statistical predictors, the predictors are not strong. And so they come out with some small scattered numbers with low odds ratios effectively, which makes it a bit more difficult to think of what are the key things that drive resilience as a whole. There's also methodologic challenges. Different shocks are not that commensurate with each other. If you have a massive tsunami versus a civil war, how do you put these on the same scale so that you can compare the severity of the shock? Then different shocks and locations can result, geographic locations can result in diverse results. And so the different papers lack a kind of coherence in their findings. There's little longitudinal follow-up beyond going out perhaps to immediate recovery. And there are no shock-on-shock studies where shocks may occur in multiple waves. So that leads to some research questions that the literature suggests could be pursued. What variations are there across small countries, and how might these differ from the variations within high-income countries? What are mediators and modifiers? What interventions could be demonstrated to improve resilience? What are the legacy downstream far-reaching effects of something like COVID-19? Well, we don't know yet because we haven't lived long enough through this crisis. But for some other ones, it's clear that, for example, inequities in the public actually increase. People draw down things such as their savings. This might put them into poverty, and that might impact their health care, but also the whole national resilience. There are specific strategies in recovery. What are they? What works? How do we learn from an event? Can we adjust our research ethics so that research can be done in an ethical manner during a crisis or a disaster? And that is covered in the literature a bit. And the potential for reconfiguration and transformation. What is that potential, depending upon the type of shock and the system that's shocked? So then we come to this major question that I was really interested in, which was what's the interface between the healthcare system and a national resilience? So historically, national resilience started out thinking about the military and then went into various areas, including social determinants of health, and having policy built around those kinds of things. So there is a natural emerging intersection, I suppose, between these two areas. They could just be overlapping because each, health as a fundamental component of civilization, as McMaster University claimed in 1991, and then governments looking at the Sustainable Development Goals and so on. These large senses of everything can be put into one basket means that eventually the two baskets, if they start out separate, might end up just being completely synonymous. So what are the claims of importance? Because certainly several authors have claimed this. So 2018, the health system response is a key feature of resilience. A well-integrated system is required, grounded in community. Policy brief of the WHO, understanding HSR, has never been more essential. And then Barnier, in a sort of editorial, basically said that health is a determinant of national resilience, but there are actually no studies at that point that actually evaluated these two things together. And certainly this scoping review confirms that really there's nothing out there. So potentially health reaches not only internally to integrate, but also to non-sector areas outside of itself for pan-resilience through, for instance, education in the schools, advocating for policies for the government, and so on. So then what is the hope? So where do I end up? What shore do I arrive at after this journey of the scoping review? So here's the start towards perhaps a model that takes into account everything that I've just covered. So what we've got is HSR on the left and we've got NR on the right, and we want to see the reciprocal relationship between these two. Now, shocks can occur anywhere in this, across this spectrum. So, for example, there could be nutrition issues if there are supply chain problems for food. There could be the energy grid going down, meaning that we don't have radiology services in the hospital. There may be a pandemic which kills off many of the workers so that we actually have fewer workforce capacities. So you can see how a shock can come in from any direction. And then the issue is, how does it move through this system? If these little things here are connected in some way in different relationships, what in fact is ultimately the impact on things? So the vulnerable groups in society are being looked at, the emergency services, public health. So papers are covering these things, and the issue is, how can we connect these parts together into a better model that might then start to allow us to look at plans for resilience in each of the areas, and then how do these integrate into a pan-resilience? So there's also some dimensions to cover. And so I just summarized some of those. So we have types of choices, for example, types of challenges. So we have choices that we make, which may have knock-on effects, and we might make a bad choice and create a crisis. We have chance events and stressors, unknown and novel, and they may be random, and these may become shocks. And we also have contingencies, such as a solar flare that wipes out the electric grid for a few months or longer. So we might have contingencies to plan for. So we have multiple types of challenges. We have different levels, integrations, and dynamics to consider. So when we're thinking about a dynamic model, we're going to have levels that go from micro to macro, local to international, biological to planetary. And then we're going to have integrations, which are vertical, lateral, diagonal, and temporospatial between what's happening in different parts of the model. And then we have dynamics such as, is this cyclical? Are there perturbations, or are there deformations from catastrophes that are going to persist? Now, there's types of resilience, as we mentioned, everyday, homeostasis, allostasis, and coping. And then there's transformational, intergenerational resilience, and then civilizational resilience. So, we had the fall of Rome, and then Rome basically as a civilization disappeared. So there's been many civilizations. So is the Western civilization, if it's worthy to keep, is that something that is able to have resilience so that it can continue, or is it going to collapse? Now, when we look at some of the dimensions on a multidimensional grid like X, Y, Z kind of coordinate system, we have issues to deal with, such as, do we go for more knowledge, or do we go for agility? Do we go for interdisciplinary responses, or are they interdisciplinary? Do we go for a technocratic artificial intelligence strategy like the World Economic Forum, or do we go more for an organic bottom-up system that is a complex adaptive system that can respond to things rather than a standardized technocratic approach to managing a shock? And then do we just extend our knowledge a bit, or do we start thinking about new paradigms? What do we actually mean by resilience? Is there a larger paradigm that would embrace everything? Or is it just an ironic situation where we have multiple power centers, we have multiple competing issues, we cannot negotiate some kind of an effective overall model? And as a result, we just have to then muddle through trying to leverage which modes of power and which available resources there are in any given circumstance in a very pragmatic way. So in summary, resilience is a powerful galvanizing concept, but the definition is not quite complete at this point. The literature is spread out, disorganized, and confusing. It's too early to integrate the knowledge for a model to guide action. There are many considerations and variables. The supporting evidence is scattered, weak, and it lacks coherence. And more thought needs to be given to what are the priorities, not just meeting the challenge, but what are the key drivers within different parts of a potential model where we could perhaps reduce the model a little bit for insight and simplification without losing the power of the model to be able to guide us. So the interface of healthcare and system resilience and national resilience is quite interesting. It's a very innovative focus, and it needs a lot more research. So thank you very much. That's the end of the presentation. So willing to take questions. I'll just stop the share there.
Indeed, very interesting. So we will open up for questions at the moment. Are there any questions from the audience? Are there any questions? So
just a comment, if you don't mind, Dr. Williams.
Sure.
I'd like to congratulate Dr. Jones for putting this together, and it wasn't just talking off the top of your head. I know that you did what you would normally do, which is to go into the literature and bring it all together. Thank you very much for the delivery.
You're very welcome, and thanks for the opportunity to present these results.
So, Dr. Jones, bearing in mind that there are all countries at some point probably face shocks, are there any guidelines in terms of what we consider reasonable periods for recovery or return to baseline given shocks and resiliency?
Well, the long-term effects haven't really been studied very well. So, for instance, in COVID-19, there's a number of suicides affecting families. Children have not been at school in some places for a year or two. And that these things will have potentially a generational impact. So it looks like, it's just a pandemic essentially. And, once we get vaccines and we get out of it and the virus mutates, we're all going to be fine and we'll go back to normal. And that was certainly the hope, a 2-week shutdown, and then everything will be normal. And then it was, we all get vaccinated and then everything will be normal. But we're not in a normal situation. We've got legacy effects. We've even reconfigured. We've got telehealth and telemedicine, things that we really didn't put a lot of effort in before. So I'm not really sure if we know enough about the dynamics yet to be able to conclude that there's a typical time.
Okay, thank you very
much. It's a good
much.
question, but I don't think we know enough.
Thank you. Dr. Etienne, please.
Thank you, and let me thank Professor Jones for this presentation. So I am one of those, of course, a health systems advocate and expert, and we are into the whole resilience issue in the Pan American Health Organization. But for me, it was interesting how you looked through the literature, and certainly the thinking behind resiliency, national resiliency, and how health systems or healthcare fits into this. And the way that you've used that to help in terms of scope and review towards a model of framework, particularly for research questions, and because there are many gaps in the knowledge and in the understanding. So when you listen to my presentation, it really illustrates this whole questions of issue on resilience and the multifaceted nature of resilience and health systems. So thank you. I think these are very good supporting presentations. So I thank you very much.
Yeah, thanks. Looking forward to yours. Yeah.
Thank you so very much, Dr. Jones, and we look forward to having you soon once again.
Yeah, thanks. Okay.
Okay, so we are now going to move on to some of the research which would have been done by our local team. And so our next presentation is from Dr. Shavette Stevens, who is a recent DM graduate, a pediatric specialist. And her presentation this morning is on descriptive analysis of acute lower respiratory tract infections in children 2 years or less at the Princess Margaret Hospital, Pediatric A&E Department. Dr. Stevens, please.
Good morning. My name is Dr. Shavette Stevens, and I will be presenting today descriptive analysis of acute lower respiratory tract infections in children 2 years or less at the Princess Margaret Hospital Pediatric Accident and Emergency Department. I have no disclosures to make at this time. Child mortality rates in developing countries are 8 times higher than those observed in developed countries. The leading cause of morbidity and mortality in acute lower respiratory tract infections in both developed and developing countries. 120 to 156 million cases of ALRTIs occurred globally. Chobra et al. Noted that there was a higher incidence of ALRTIs in the first 2 years of life. ALRTI is not a single disease entity, but it is a group of infections with different etiologies, risk factors, pathogenesis, clinical presentations, and outcomes. Ungadi et al. Noted that the common types of ALRTIs are pneumonia and bronchiolitis. Regarding bronchiolitis, RSV is estimated to be the cause of nearly 34 million cases of ALRTIs per annum in the United States. ALRTIs are affected by sociodemographic and sociocultural factors, which are modifiable by simple interventional measures. The rationale for this study is that ALRTIs is one of the most common reasons for parents consulting health professionals. And currently, no research exists in the Bahamas regarding the prevalence of ALRTIs. Thus, for research, it is important to provide the necessary preventative measures to avoid the unnecessary use of antimicrobials. It is vital to recognize the signs, symptoms, and risk factors early in order to reduce the severity and occurrence, as well as to provide effective medical care to decrease the disease burden. The objectives of the study is to describe the socio-demographic profile of the participants selected for this study, to determine the period prevalence of ALRTI in children aged 24 months or less who presented to the Princess Margaret Hospital Pediatric Accident and Emergency Department over a 5-month period, to determine the various types of ALRTIs, to describe the clinical characteristics of ALRTIs, and to determine other possible factors that are associated with ALRTIs, for example, environmental studies, immunization status. The method was a retrospective descriptive chart review in individuals who was diagnosed with an acute lower respiratory tract infection, that being either bronchiolitis, pneumonia, or croup. For example, children greater than the age of 1 month to those less to 24 months of age during the study period of May the 1st and September the 30th of 2018, who met the criteria of an ALRTI. They needed to have one or more of the following clinical signs: either cough, difficulty breathing, tachypnea, stridor, cyanosis, and on auscultation, crackles and wheezing. The results and discussion. There was a male predominance in this study, that being 58.2%, followed by females of 41.8%. Bahamian nationality was the most commonest, that being 77.9%. And the mean age of participants was noted to be 10.77 months. During the study period, 4,284 participants presented to the Pediatric Accident and Emergency Department. Of that, 459 were documented cases of ALRTI, 10 were repeat cases, as well as 114 cases met the inclusion criteria but had to be excluded because dockets could not be found. Therefore, 335 cases of ALRTIs were used. The period prevalence was noted to be 8.3%. Of note, the prevalence found in the study of PMH was lower than that demonstrated by the World Health Organization when they looked at a developing country. For example, they looked at India, and they noted that the prevalence rate for ALRTI was noted to be 15.21% in children younger than the age of 5. The differences in the proportions of ALRTI found in this study could be a result of different study populations as well as different study settings. For example, the duration of the study period, or even differences in the age group studies. In this study, we looked at those that were less than the age of 2 years. In their study, they looked at kids who were older than the age of 2 as well. Bronchiolitis was noted to be the most common clinical entity associated, that being 74%, followed by wheezing-associated respiratory illness of 14%, bronchopneumonia of 6.6%, croup of 2.7%, and pneumonia of 2.4% of the cases. Of note, the box plot below, for the participants diagnosed with bronchiolitis, the median age of presentation was noted to be 9 months. In addition, it was also found that the lower age group, or those less than the age of 1, were more at risk for being diagnosed with bronchiolitis. Conceivably, this could be due to the fact that bronchiolitis is caused mostly by RSV infection, which is acquired mostly in this age group. Additionally, due to the fact that the immunity has not become fully established, incomplete development of their lungs, narrowed airways, and a relatively short bronchial tree places them at greater risk. The highest occurrences of ALRTIs were observed in the month of July, that being 87 cases, followed by May, 82, and June, 75, which happens to be the rainy season with relative humidity averaging high at 65%. The lowest occurrences were seen in the months of August, that being 47%, and September, that being 44% of the cases. And this could be due to the seasonality of the infective agents themselves, or the time of the increased risk for acquiring ALRTIs. Unfortunately, only one seasonal period was reviewed in this study, and there may have been an underestimation of the cases of ALRTIs to determine the true seasonal pattern in the Bahamas. This slide shows the symptoms of the ALRTIs found in the cases. Difficulty breathing was found in 51.6% of the cases, followed by fever, that being 49.9% of the cases, and a wet sounding cough of 44.8% of the cases. Some of the most common clinical signs found was a resonant percussion note, that being in 74.6% of the cases, wheezing being 65.7%, and respiratory distress, that being 63% of the cases. This slide shows the relationship between statistically significant various clinical signs and symptoms for ALRTIs. Regarding bronchiolitis, there was a 1.7-fold increased chance of having wheezing and a 1.8-fold increased chance of having a dry cough with those participants who were diagnosed with bronchiolitis than those who were not. Interestingly, in this study, there was a 3-fold increase, or 11.9%, chance of being diagnosed with pneumonia when rhinorrhea was present compared to those who did not, of that being 4%, have the symptom. Moreover, there was a 10-fold increase of a barking cough, a 6-fold increase of a respiratory distress, and an 8-fold increase of crepitations and crackles and auscultations in participants who were diagnosed with pneumonia than those who were not. Risk factors. The highest occurrence of bronchiolitis occurred in babies with formula feeds only, that being 83.3%. Mixed formula feeds had an occurrence of 79.3%. Breastfeeding for less than 6 months had an occurrence of 76.6%, and breastfeeding for 6 months or more had an occurrence of 54.7%. The data shows that any amount of breast milk is protective, and this is likely due to the protective effect of maternal milk that the infant is exposed to. It has been hypothesized that breastfeeding enhances the antibody response to the important respiratory pathogens. Not surprisingly, completely immunized participants had a lower occurrence of pneumonia, 5.1%, when compared to those who did not, 17.1%, thus showing that an ineffective immunization status leads to a high occurrence of pneumonia, and this difference was found to be statistically significant. It is the researchers' belief that it can be postulated that the higher percentage of participants who were not completely immunized did not receive immunization against common respiratory pathogens, for example, Streptococcus pneumoniae or even H. influenza. Respiratory syncytial virus testing was performed on 121 participants, and 37 of those were noted to be RSV positive. There were no bacterial pathogens that were isolated at this time. And one can theorize that with vaccination and efficient immunization programs of common respiratory pathogens, that there would be a decline in the recurrence of these diseases, and is likely why no bacterial pathogen was actually isolated in this study. The disposition. The majority of the participants, that being 93.4%, were discharged. Of those regarding bronchiolitis, of the 22 participants who were admitted, 9 of those were admitted to children's ward, and the median length of stay was noted to be 5 days. For pneumonia, of the 9 participants who were admitted for pneumonia, 2 of those were admitted into the pediatric ICU, and the remaining 7 had to be admitted to the children's ward, and the median length of stay was noted to be 7 days. Limitations. There was insufficient documentation in the medical records. The study period was noted to be just covering the summer months. And participants were diagnosed clinically by the physicians who examined them. Thus, interpretations of the various ALRTIs subgroups may prove challenging at times, therefore making it, because they overlap, and therefore making it difficult to differentiate the illnesses. In conclusion, ALRTI was reported to have a lower prevalence when compared to the global rates. Incomplete immunization and lack of breastfeeding were were risk factors. Community-based programs should include identification of severe respiratory illnesses, provide access to health care, good hygiene, and breastfeeding in order to decrease the incidence of and morbidity and mortality of ALRTIs. The recommendations are prospective surveillance over an extended period of time to document the true incidence of ALRTI in Nassau, the Bahamas is recommended. Additional variables should be entertained, for example, nutritional status, the size of the homes, for example, should be studied to determine the factors that increase the risk of ALRTIs, confirming access to timely and appropriate health care in order to decrease the amount of unnecessary antibiotic use and investigations, maintaining effective immunization programs, and employing efficient breastfeeding programs to provide the ideal form of infant nutrition and the many protective effects it has on infant respiratory health. I would like to acknowledge Dr. Marcia Bassett and Dr. Anthony Frankson, as well as the Princess Margaret Hospital Pediatric Department, the staff of medical records, and administrative support. These are my references.
Are there any questions at this time? So Dr. Stevens, I noticed that your study had been done back in 2018, and certainly a lot has happened since 2018 in terms of the pandemic. Do you have any thoughts on how the pandemic would have affected ALRTIs during that period of time? And now that we're coming out of it, do you wish to comment on that?
Yes, good morning once again. Can you hear me, sir?
Yes, we can.
Okay, great. So when you look at it, I'm sure you've all seen in international news as well as news that we have currently right now locally, is that you will see that the occurrence of respiratory illnesses coming to the accident emergency department or primary care health facilities or even community clinics have had an upsurge. And that could be likely due to the fact that, kids were isolated because of the pandemic for about 2 to 3 years. They weren't exposed. Their immune system, wasn't exposed to certain common respiratory illnesses. So it's now that they're now being exposed, it's like a culture shock to their bodies. So you have kids now who's coming in and they are a lot more critical than say if they were exposed over a repeated amount of time previously before the pandemic. So I think that the study actually needs to be explored even more. In particular, it'll be interesting to see what the results are during the pandemic and even after the pandemic, to see currently now what our true rates are, because I'm sure they would be exponentially increased significantly. So it just once again just proves the fact that immunization programs and a lot of the parents have not been taking their kids to the clinic because, they assume that the clinics were closed. So a lot of our kids are immunization defaulters too as well. And even though the study was done in a short period of time, it still shows the need of, when you're completely immunized, it does protect you against some of these common respiratory pathogens.
Thank you, Dr. Stevens. Are there any other questions for Dr. Stevens? Thank you so much. We look forward to the continuation of your study going forward. Thank you. So our next presenter, Dr. Lakeisha Brown, is also a recent graduate of the DM program locally. So she is a pediatric specialist, and she will be presenting on evaluating the critical congenital heart screening program at the Princess Margaret Hospital since implementation in 2016. Please, Dr. Brown.
Good morning. My name is Dr. Lakeisha Brown, and this morning I will be presenting my research paper evaluating the critical congenital heart screening program at the Princess Margaret Hospital since implementation in 2016. My co-authors are Dr. McDigan, Dr. Franks, and Dr. Mansrule. I have nothing to disclose for this presentation. These are my objectives. And let's begin. Congenital malformations are well-known explanations of infant death, with congenital heart disease being the cause of more neonatal demise than any other. Congenital heart disease is an overall term representing a spectrum of structural defects of the heart, resulting from malformations of one or more parts of the heart during early stages of embryonic development. Congenital heart disease exists in 7 to 9 in 1,000 live births in the US. A study done in the Bahamas between 2012 and 2014 by McKinsey et al. Shows that the average incidence of congenital heart disease was 12 per 1,000 live births. Critical congenital heart defects refer to a group of heart defects which impair the blood supply to pulmonary and/or systemic circulation. These conditions are life-threatening diseases requiring urgent surgical or catheter intervention. And here is a list of the critical congenital heart defects that we considered in this study. In 2009, the American Heart Association and the American Academy of Pediatrics recognized pulse oximetry as a method of detecting critical congenital heart disease. The Secretary's Advisory Committee on Heritable Disorders in Newborn and Children, in collaboration with the AAP and the American College of Cardiology Foundations, convened a working group to outline implementation strategies for pulse oximetry monitoring for critical congenital heart disease. In 2016, a critical congenital heart disease screening program was implemented at the Princess Margaret Hospital based on these same protocols. All neonates delivered through the public system of the Princess Margaret Hospital were required to have a screen done prior to discharge. The algorithm was as follows. A screen result was considered positive if any oxygen saturation measures less than 90%. Or if oxygen saturation is less than 95% in both extremities on 3 measures, each separated by 1 hour. Or there is greater than 3% absolute difference in oxygen saturation between the right hand and foot on 3 measures, each separated by 1 hour. Any screening that is greater than or equal to 95% in either extremity with less than or equal to 3% absolute difference in oxygen saturation between the upper and lower extremity would be considered a pass result. Blood pressure readings were added to the screening at the Princess Margaret Hospital to ensure the capture of left-sided obstructive heart lesions. A study done in Germany showed that pulse oximetry screening does not reliably detect left heart obstructive lesions, which represent 75% of false negative cases. Coarctation of the aorta and interrupted aortic arc was responsible for 27% of the deaths due to unrecognized critical congenital heart disease. This raised the question of whether adding blood pressure measurements would further lower the number of infants with unrecognized critical congenital heart disease prior to discharge from the newborn nursery. We hypothesized that screening at 24 hours of life would decrease false positive rates by 50% in detecting critical congenital heart disease. Pulse oximetry combined with blood pressure screening will detect at least 75% of the critical congenital heart disease, inclusive of left heart obstructive lesions. Our objectives were to assess the timing of the screen, to determine the positive versus the negative screens, to identify if there was a pattern of critical congenital heart disease detected by the screening program, to determine if blood pressure measurement is required as an adjunct measurement of screening, and to determine if parents are being counseled about the screen. It was a retrospective review of medical records of patients with a failed heart screen, those admitted to the NICU for possible cardiac pathology, and those readmitted to the Children's Ward Nursery for cardiac pathology. Our population were all late preterm to term newborns discharged from the public maternity nursery and infants admitted to the NICU for failed screened or possible cardiac pathology due to hypoxia. Based on the study done in 2012 to 2014 by McKinsey et al., we postulated that the incidence of the congenital heart disease would be 12 per 1,000 live births. Using Cochrane's formula, 2,025 was the minimum number of screens that was required to be reviewed. We included all of those who were born between 2016 to 2018 through the public maternity nursery at Princess Margaret Hospital, those who had a screen done prior to discharge, and those admitted to the NICU for failed screens or ruled out congenital heart disease. We excluded anybody that was delivered or admitted to the private maternity nursery preterm at 23 to 34 weeks, and those multiple congenital anomalies. Descriptive statistics, including measures of tendency and inferential statistical analysis, were done. Bivariate and multivariate analysis were also used for complex relationships. During this time period, a total of 7,076 screens were done. However, 1,588 were not included because of incomplete documentation. The mean gestational age was 38 weeks, with a mean birth weight of 3,081 grams. The median hours of life for the first screen was 28 hours. A total of 76% of the screens were done between 24 and 72 hours of life. 21% was done less than 24 hours of life, and 1.7% was done greater than 72 hours of life. The median for all the mentioned groupings at first screen was statistically significantly different from each other. This shows the results of the first screen. 97.5% passed the first screen, which was 5,350. 2.5% failed the first screen, which was 137. Of those that failed the first screen, 6.2% were done less than 24 hours of life. 1.4% was done between 24 and 72 hours of life, and 2.8% were done greater than 72 hours of life. The reason for the failed screened was about 80% for those with abnormal blood pressure reading who failed the screen. Compared to live births, from the start of the program to 2018, in 2017, we see there was a slight increase of the screens compared to 2016, but a slight decline in 2018 compared to 2017. During the time period of this study, there were a total of 19 admissions to the NICU for query cardiac pathology. However, only 11 charts were available for review. And the reasons of admission included cardiac murmur, abnormal ECG, failed CHG screen, hypoxia, congenital pneumonia, and an infant of a diabetic mother. On review of the investigations done on the 11 charts, we noted that 7 did not require any further evaluation, meaning no EKG or 2D echogram. Of the 4 that did have a 2D echogram, results showed that 1 had atrial septal defect, one with anomalous pulmonary venous return, one with pulmonary hypertension, and one with tetralogy of Fallot. As you can see on the screen, those who failed the CHG screen, one was noted to have a critical congenital heart defect, anomalous pulmonary venous return. Of those that failed because of abnormal blood pressure readings on evaluation did not have an obstructive left heart lesion. A total of 19 infants was readmitted to Children's Ward for queried cardiac pathology during this time period. However, only 12 charts were available for review. The median age was 1 month. Of the 12 that was available, 6 of them were noted to have a CHG screen for which they passed. 2 done with less than 24 hours of life, 2 between 24 and 72 hours of life, and 2 with no documentation of age. Of the 6 that did pass the screen, 4 of them were diagnosed with a congenital heart disease. 1 with a critical congenital heart disease, double outlet right ventricle. Of the remaining infants whose screens were not available, 1 was done born prior to implementation of the screen, and 4 were admitted to the NICU for various reasons other than cardiac pathology. This study suggests that screening at 24 hours of life decreases false positive results. An increased false positive is expected in neonate screen within the first few hours of life. Based on this study, we are unable to state if blood pressure readings combined with pulse oximetry will increase detection of critical congenital heart disease. Positive screens due to abnormal blood pressure results in high false positive rates. Belke and Hoxton noted that pulse oximetry can detect right to left shunting through a significant PDA, which is expected to be present upon routine discharge 24 to 72 hours of life. Ductal restrictions or closures are unlikely to occur at time of discharge from hospital. Hence, blood pressure screening is less likely to be effective. From this study, we noted that 1 infant with a positive screen, meaning that they failed the CHG screen, was noted to have pulmonary anomalous venous return. 1 infant was also readmitted at 1 month and was noted to have a double outlet right ventricle. However, screening was noted to be negative, but there was no documentation of the age at the screen. There was 1 infant who was diagnosed with tetralogy of Fallot. Screen was not done due to early signs manifested before recommended time of screen. As noted in a study done in Thailand, 63.2% of critical congenital heart disease cases were detected before pulse oximetry screening. My limitations include incomplete documentation of the screens, neonates who were directly admitted to NICU were not screened, and medical records not available for review. We can conclude that screening on the maternity ward was effective in identifying a critical congenital heart disease, although sensitivity of the screen was at most 50% with a specificity of 99.9%. Strong specificity and need for continued efforts toward enlarging sample size are reasons to recommend that this be continued well into the future to clarify the sensitivity in identifying neonates with critical congenital heart lesions. I would like to acknowledge my supervisors, Dr. McDigan, Dr. Mansroll, and Dr. Frankton, and thank the nurses of the Public Maternity Nursery and the residents and staff of the pediatric department at Princess Margaret Hospital. These are my references. And thank you for listening.
I will certainly start off the questions, Dr. Brown. So we know that obstetrics and gynecology and pediatrics make up an awesome team. In terms of actually screening by ultrasounds, do you know if ultrasounds are being done in adequate numbers to screen for cardiac abnormalities early in pregnancy? And if so, what impact might that have on the actual screenings after delivery?
Whether or not the ultrasounds are being done at the right time in terms of obstetrics, but for those who have been getting scans done, and we do know that there is some cardiac pathology, we get informed right away when they do find out, and we get our cardiologists involved as best as we can. Even though we don't have one available right now at the hospital, but for those who can't afford the private services, we do get them involved, Dr. Lightburn involved as soon as possible, and he can better guide us to what needs to be done, how the delivery should happen, and what needs to be done after the baby is born.
Great. And so you had over 1,500 notes that were not able to be included in your study. Has the department taken any steps to prevent that from happening going forward?
Going forward, yes, we have. In terms of documentation, we are much better at documenting our screens, the hours of life, the birth weight, gestational age, so that we can, and the nurses are much better at doing it as well, so that we can better assess our patients before they are discharged. We have taken it under consideration.
Okay. Thank you so much for a very interesting presentation, Dr. Brown.
Thank you.
And so we will move on to our final presentation, resident paper presentation for this session. And this will be done by a family medicine specialist, Dr. Tessa Gibbs. Her presentation this morning is on parental perception, knowledge, and practices related to unintentional injury among toddlers in New Providence, Bahamas. Please, Dr. Gibbs.
All right, morning everyone. I am Dr. Tessa Gibbs and will be presenting my research entitled Parental Perceptions, Knowledge, and Practices Related to Unintentional Injury Among Toddlers in New Providence, Bahamas. And at this time, I have no disclosures. The World Health Organization states that approximately 2,000 families worldwide are affected by childhood injury every day, with similar accident rates by sex in the toddler age group. In a retrospective study by Cartwright et al. In Nassau, Bahamas, it was found that overall, injuries were a leading cause of pediatric deaths. In New Providence, news reports in 2017 and 2022 highlighted potentially preventable deaths of a 2-year-old girl and 1-year-old boy, emphasizing the need for more attention to this subject. There were a total of 64 articles used in this study, and I'd like to share a few of them with you. Romano et al. Conducted a statistical review which showed 19% of children were injured in motor vehicle accidents, and that children ages 3 to 5 are more likely to be ejected while in the front seats of vehicles. In a retrospective chart review conducted in Antigua, Martin et al. Found accidental poisoning substantially involved the toddler age group, and the most frequently ingested chemical in this study was bleach. Pillay et al. Found in Trinidad that among toddlers, kerosene was the predominantly ingested chemical. A prospective surveillance study in Jamaica by Vincent et al. Revealed the majority of children affected by burns were boys, and the most common age group affected were toddlers under the age of 2 years. According to the WHO European Report on Child Injury Prevention, children 1 to 3 years of age were most likely to fall from heights. Also, regional studies in Barbados, Jamaica, and Trinidad revealed falls were the leading cause of injury among children. Studies also sought to determine parents' knowledge of child injury prevention. Cross-sectional surveys by Lafter et al. And Sumakis et al. Both showed poor level of knowledge among parents. Su et al. In a qualitative study found most mothers believe that accidental childhood injuries were more likely with the absence of parental supervision. Other studies by Lafter et al. And Thine et al. Found that parents preferred to receive information from their social circle and their physician. A cross-sectional survey by Ince et al. Showed that toddlers represented the majority of children involved in this study, and parents generally had poor practices. Abel-White et al. Learned that parents can adapt to make environmental changes in an effort to improve their children's safety. Previously, there were no other studies on unintentional accidents in the toddler age group or studies on parental practices, knowledge, and perceptions toward child injury prevention that exist in the Bahamas. This study may help to establish education and counseling techniques for our particular population. The aim of this study was to determine parents' and guardians' knowledge, perceptions, and practices on the prevention of unintentional injury among their toddlers at primary healthcare clinics in New Providence, Bahamas. The objectives of this study were to determine parents' and guardians' knowledge level, areas of deficiency in recommended practices, views surrounding injury prevention education, types of accidents, and the socio-demographic profile of participants. This research project used a cross-sectional study design and was conducted from June to August 2021 in New Providence Island. The sampling technique used a non-probability convenient sampling of the 5 major public health clinics. Inclusion criteria included being 18 years or older, being a parent or guardian of a child between 1 to 4 years of age, being competent in the English language, being present at public health clinics, and giving consent to participate in the study. Those who didn't meet this criteria were excluded. The calculated sample size needed was a minimum of 246 participants. The main instrument used for this study was a questionnaire, which took approximately 20 minutes to complete. The de novo component of the questionnaire achieved content validity through the review of 6 pediatricians and used the Framingham Safety Survey, which is widely used by the American Academy of Pediatrics and was previously validated by Hatfield et al. Confidentiality was maintained throughout, and data was entered into the IBM SPSS statistics analysis software, and descriptive statistics were used. Permission was sought from the relevant ethics committees, and educational pamphlets were explained and given to participants as well as non-responders. There were a total of 279 respondents, and females composed 89% of adult participants. The median age of the adult participants was 28 years old. The modal race was Black or Afro-Caribbean. The modal nationality was Bahamian. 64.4% of participants indicated they were single or had never been married. 53.8% of participants listed completing high school as their highest level of education. 43.6% of participants reported a household income of $2,000 to $4,000 Bahamian dollars per month. This was followed by 33.5% of participants that reported a household income of less than $2,000 per month. Regarding toddlers in this study, 54% were male and 46% were female. The modal age for toddlers in this study was 1 year. Regarding the types of accidents reported, the modal accident was falls, experienced by 47% of toddlers. There were 6 admissions to hospital reported for serious injury, and this included a fall resulting in intracranial hemorrhage, burn from a clothing iron, a shoulder dislocation, and a head injury. These admission periods varied from 4 days up to 1 month. Participants' mean knowledge score was 60.7%. The lowest score was 10%, and the highest score was 100%. Of note, lowest knowledge scores were on fall prevention and the use of forward-facing car seats. Regarding parental perceptions, 55.1% of parents stated they were very comfortable with their current knowledge level, and friends and family were the greatest source of this knowledge. 28.7% of participants reported never receiving accident prevention advice from clinic, and 53.3% preferred learning directly from the doctor or nurse. 71.4% of participants felt it was the doctor's responsibility to educate parents on accidents, and 98.9% felt it was their personal responsibility to gain accident prevention knowledge. Based on responses from participants, areas that were found to have poor practices were in the areas of fire and burn prevention, poison and choking prevention, and car safety. From the results, the representative participant in this study was a single Black Bahamian female in her mid-20s with an average household income of $2,000 to $4,000 per month, which was the expected demographic at public health clinics based on observations. Educational level in this population revealed most participants to have a high school education as their highest educational level, which was also demonstrated in studies in Qatar and Hungary. The study showed that 62% of toddlers experienced one or more accidents. This similar accident rate of approximately 60% was also reported in Italy. However, much lower accident rates of 25, 35, and 39% were reported by other studies. In the study, 47% of participants reported falls. This result was also seen in Italy, Hungary, Singapore, and South Africa. Falls are common throughout this age group in countries all around the world, which is likely due to the exploratory nature of this age group mixed with immature judgment and developing motor skills. The mean knowledge score in this study was 60.7%. This exceeded the researchers' expectations. Other studies in Nepal and Malaysia also demonstrated knowledge scores comparable to our study participants. In this study, only 7.3% of participants responded they felt like an expert in child injury prevention, yet still had an average knowledge score of 60%, which was comparable to the rest of the participants. This may suggest that some parents may lack insight of their true knowledge level. Approximately 7 in 10 participants stated they felt it was the responsibility of their child's physician to counsel on injury prevention advice. This suggests that advice physicians offer would be well received by our population. In this study, 87% of participants reported not having a fire extinguisher, 79% did not have a smoke alarm in the home, and 40% did not have a fire escape plan. A study in Turkey reveals similar results, with 83% of participants not having a smoke detector or fire extinguisher in the home. Only 39.9% of participants in this study were found to have used the correct car seat. Other studies reported even lower car seat use in Turkey, the United Arab Emirates, and Iran. However, another study conducted in South Wales demonstrated up to 83% of car seat use among participants. This may suggest that developed countries have higher car seat use compared to developing nations. To my knowledge, this is the first study in the Bahamas that sought to determine the knowledge, perceptions, and practices of unintentional injuries of parents regarding their toddlers. This study found that overall, parents had good knowledge level, were receptive to advice from physicians, and had major deficiencies in fire safety and burn prevention. Limitations to be considered in this study include recall bias, as the study was dependent on the parent's ability to recall accidents since the child turned 1 year of age, and this recall period was longer for parents of older children. Another limitation was the physical closure of some clinics, whose populations were redirected for service to other clinics. Due to these changes, the study may not reflect participants who postponed children's visits because of this, and thus may not be represented in the sample. Several recommendations include the development and utilization of an established electronic-based system that Bahamian parents can access to periodically test knowledge and gain advice based on the child's age and can be shared with other adults in that child's circle. A collaboration between the Ministries of Health and Education to form a team that can promote parental education through local public and private preschools. Also, the Ministry of Health can collaborate with local telecommunication and internet providers to deliver bulk injury prevention tips on a regular basis to the community. Further research can be done with qualitative studies among parents seeking to understand any challenges with putting recommendations into practice. Also, studies involving physicians to determine challenges faced with disseminating accident prevention advice should also be explored. I would like to acknowledge and thank my supervisors and librarians for their help in this project. These are my references. Thank you so much for your attention.
Thank you, Dr. Gibbs. And so we are now open to questions for Dr. Gibbs. Okay, we have one question from the chat. And that is from Dr. Crystal Johnson-Roll. And the question is, I know your study was primarily descriptive, but you mentioned low car seat use knowledge among parents. Do you have any thoughts or ideas to why that may be?
Okay, so thank you for that question. You're right, less than 40% of the parents had adequate car seat use. And this study was mainly done among the public clinics, and most of the descriptants would be classified among a lower socioeconomic level. So the possibilities could be car seats are expensive. It is quite possible that maybe affording a car seat could be a challenge. Also, for some persons in the lower socio-demographic level, public transportation could be a main means of transportation. The families may be able to afford or may not be able to afford private vehicles for every person in the household. And so, or maybe depending upon their level, no one. And so public transportation use may be used more among those persons. Now, our traffic laws actually in the Bahamas aren't so heavy among the public transportation vehicles. From what I could recall in my research, the bus drive, if you're catching the bus system only requires that you have seatbelts. And I can also imagine that a mom carrying a car seat, if she has to walk and catch the bus, can also be cumbersome as well. Also, what comes to mind is that some persons in that socioeconomic level may have more children. And if you were to count the number of seats in the cars, if you have more than 3 kids, you wouldn't be able to fit those car seats in there. If you have a 1-year-old, a 2-year-old, a 3-year-old, and a 4-year-old, you may end up not being able to fit those car seats in because it's a driver's seat, a front passenger seat, and then 3 spaces in the back. So that would definitely present a challenge for persons who have more than 3 children and for those who can still afford a private vehicle. So those are some of the things I think that may contribute to low car seat use among the persons in my study.
Okay. Thank you, Dr. Gibbs. And one final question, quickly, please. This is from Dr. Kalma Andrea. Good morning. Your findings on car seat use were not surprising, as we often see parents driving with children in their laps.
That's true.
At the steering wheel. Were your findings shared with the Traffic Police Department?
Okay, so no, not as yet. But you're right, because even in my own observations, I would pass a car in traffic and I would actually shout out to the person, the baby needs a car seat. I remember that doing that at least twice. And I remember one child was really young, like she looked as if she had just gotten discharged from the hospital. The mom was driving in the front, and the grandma was holding the infant in the back seat. And I could see that they looked like they were surprised, but also concerned. And I think that once there is some care and compassion, and you understand the devastating effects that could result if that car were to get in an accident. And it doesn't have to be the driver's fault. You can be the best driver on the road. But if there's another person who is driving erratically and hits your car, then that child is now at risk for being ejected and at risk for death. And the truth is, we recommend these constantly as a everyday practice because you don't know when you will get in an accident. I do think that Dr. Culmer did raise a good point in terms of sharing it with the traffic police so that they can be aware. But I do know that there are some police that are definitely looking out. I can remember a family member of mine last year got booked for not using the proper car seat, for not having his child in a car seat. So they are out there, but definitely enforcement can be increased so that we could see better use among the parents, and so that they don't take it for granted that the child will just be okay. Thank you so much.
Thank you so much, Dr. Gibbs, for a very interesting presentation. And so we're going to move on to our next presentation. We had the great opportunity earlier to hear from Dr. Glenn Jones, and so he will be presenting once again. This time he will be presenting on clinical reasoning and evidence-influenced practice in medical education.
Okay, so yes, this is more of a position piece, not really based on data, and I've been working with a student to help me at the school. Presently, I work full-time as assistant dean at Saba University, one of the Caribbean schools. It's in the Netherlands, Antilles there, and accredited through the Netherlands. And our students do rotations in the United States in their clerkship years, in years 3 and 4. So what is the importance of clinical reasoning and evidence-based practice in medical education? Well, there was a survey done of residency directors in the US in 2010, and they actually said that the most important competency they desired in a resident who was applying was actually clinical reasoning. So it's difficult to grade that, however, so it makes it difficult. And so that's why in some interviews, people get asked questions such as, if somebody has this problem, explain how you would think about it. So school curricular objectives for clerkship from Saba actually point out for clinical reasoning that you need the elements of history taking, physical exam, diagnostic decision-making, and good patient communication. And evidence-based practice focuses on the aspect of self-directed learning. Now, students in our clerkships are evaluated on how well they do clinical reasoning. We have an 84 patient-centered assignment. They do 2 a week during their 42 weeks of core rotations. This could lead to better rotation evaluations, reference letters, comments for school summary in the MSPE, and it could result in better exam results subsequently. So it's also true that the competencies are required. The IOM, the Institute of Medicine, and then the ACGME in the US have requirements that evidence-based medicine is practiced, but it's also taught, including taught by residents to medical students. So the US medical schools are now starting to layer in systematic EBP, starting from the year 1 or 2 and taking it through all of the years. And US residencies are also starting to emphasize a more systematic strategy for deploying and using EBP, for example. So what are the definitions? What is it that we're talking about? So here's a summary from Manchester published by Singh in 2020 that talks about what is clinical reasoning, and it's basically taking a history, doing an exam, thinking about that, integrating it, coming up with a differential diagnosis, justifying those 2 or 3 differentials, and then ordering the appropriate tests. So that's essentially clinical reasoning. Now, this is something you can do when you go to see a patient, and it does not require you interacting with the literature. You basically take in the knowledge capital you have, you apply it, and then you move on to the next patient. So what is evidence-based practice? Well, it's the integration of best research evidence with our clinical expertise and our own patient unique values and circumstances. So if you don't go to the relevant scientific evidence, it's the model I just said, which is clinical reasoning. It's the left and the bottom parts of the Venn diagram. If you add in the question of, can I get an interesting point that I need to learn something about, and then you go look up the evidence and apply it, then of course you bring in the third component. So this becomes a stool with 3 legs, and it's not imbalanced if the evidence seeking is there. So there was a consensus in 2003 at a meeting that was published in Sicily that there are 5 core competencies: asking a good question about a patient, finding the best evidence, evaluating that evidence, applying it to the patient, and then you evaluate the process. Did I do a good job? Did I ask a good question? Did I find my search strategy? Did it find the evidence I needed? And so on. But also you evaluate the outcome in the patient. So every patient is an opportunity to improve clinical reasoning and clinical practice. So what are the current physician practices when they're surveyed in terms of how well do they do this? Well, obviously they're not that bad in doing clinical reasoning because that's their core role on a day-to-day basis. But the uptake of evidence-based practice remains a physician problem. Scores of studies and several reviews demonstrate that most physicians do not. They rely on colleagues and textbooks, for example, and they do not practice EBP. This, when they do it, it's irregular and inconsistent. And because of their training and the amount of effort they've put into doing it, which is not that great, they are maybe very good at asking questions and searching, but they're not very good at appraising that literature, applying it to the patient in language that allows shared decision-making. And they do not, or very rarely would do evaluation of what just happened. There's also now, and especially with the newer graduates and residents and so on, there's an over-reliance on what I call the 4 E's. They go for English sources, electronic searching only, free sources like available PDFs, and emergent sources like they think that the best thing is since sliced bread is an article that came out last week, even if that article actually, when you appraise it, is poor, and a prior article is actually more important. Now, what do you think impedes the growth and use of evidence-based practice to refresh clinical reasoning? Well, physicians may not be sufficiently motivated. They may have poor accountabilities, poor practice cultures. Maybe they don't work in a community of practice for best practice. Then the effort that they have to put out, they may think it's simply too much, that if only 1% of publications are sufficient quality to apply, maybe that's just not worth the effort to go look for them. But there are available solutions that may help, but physicians don't appear to go to these very often. One is to distribute the work effort for looking things up, asking good questions, appraising the literature and so on, and putting them into clinical policies, is that they don't distribute the work effort over the team. So if you're teaching and you've got residents and interns, medical students and attendings, it's possible to distribute the work effort across the team so that each person only has to do a few minutes on a question, or one person gets one question and another person gets a different question, an educational prescription, in other words. Now, people do need access to more publications. So there are 40+ million publications and you need access to be able to get to most of those. But you can search for more relevant review articles and practice guidelines. And most people don't know that there's practice guidelines on things like syncope and so on until they actually stumble upon them if they don't go looking. And you can add advanced portals to get pre-appraised literature, and some of these are free. And so they expedite your actual search to get higher quality evidence. And here's a list of 4 of them, some of them from McMaster University. A couple of these are free, and they provide quicker summaries. And it's worth considering using these rather than going straight to a brute force PubMed search or trying to use the internet otherwise. So this dilemma of physicians not really doing and improving their clinical reasoning and doing evidence-based practice and influencing the practice from evidence could be a problem for healthcare system resilience, which it was the title of this presentation. And you might say, why? I mean, I've just presented details of many factors that could interact and produce national resilience. But within the healthcare sector itself, there are probably several significant drivers for the system, the healthcare system, to be resilient and therefore to be able to contribute to the national situation. So this could be a problem. So let's think about the benefits of refreshing clinical reasoning through evidence-based practice. So for example, the physician workforce is an important part of healthcare. And that's fairly obvious. Clearly, nurses and occupational therapists and others have also picked up EBP. Some of them do it better than some physicians. So I'm not suggesting that it's just physicians, but for the purposes of this talk and for medical education, schools in particular, it's the physician workforce that I'm focusing on. Now, if you have efficiencies in clinical reasoning, you order the right tests, you don't order redundant tests, you do tests appropriately at certain times, for instance, you come up with a good differential diagnosis right away and you're more accurate. And your evidence-based practice is applied in a continual way to refresh your reasoning, then this may save resources, and those resources could be allocated to building resilience of the healthcare system or be exported to other sectors in the economy and society, or physicians may be better freed up to go and do advocacy and so on. Now, shocks to the system, as I discussed earlier, may require reconfiguration of work, keeping up to date with evolving shock data and medical solutions, as we saw in COVID, with an evolving situation, and also reverting to next best alternatives. So for example, perhaps you'd normally follow a patient every 3 months, but instead you've defaulted to follow them every year simply because of the presence of COVID. So, or you flip to telemedicine, so you're not able to directly examine the patient. So you may have next best alternatives. And so knowing about the evidence and what is the next best alternative, and then going down that list is one thing you might need to do with EBP. Now, my basic fundamental point is that physicians who are good at doing these things may be of great value when resilience is needed. So they may be a key driver and an important component, as I said, of a system if you reduce the larger model down to a smaller model, but still retain the insights. One of the things that should be there is this aspect. However, when you look at the literature in that review that I did, they mention professional workforce, but not a single one mentioned that that professional workforce needs to have a dynamic that maintains and builds practice, which is the point that I'm making in this talk. So how can we improve teaching? So the first thing is to have a program-wide perspective. So from year 1 to year 4 or 5, you want to prevent student difficulties. So you need not only to assess their knowledge and the self-regulation of the student, and the student has to adapt to the clinical environment, but we should think more about strengthening the student's humanity for human connection, core values, the language they use with patients, and having courage through uncertainty. We also need assessment tools to assess how good they are at doing this kind of dynamic and then monitoring it. And then we need to improve it with regular feedback, instruction handouts, or demonstrations of things such as examining the abdomen or how to appraise a systematic review. And we could add coaching if there's any remediation needed for the student in order to bring them up to speed before they graduate from medical school. The second component is that in response to evidence-based practice, many medical schools adopted a dual track or training system where students are forced to do some research components in their practice, in their school. And of course, they develop clinical expertise in the clerkship. So students have some epidemiology and statistics knowledge, they've done a research project, and they're learning more about clinical epidemiology and biostats while they're acquiring clinical knowledge and developing illness scripts. So you can leverage this dual track and say to the student, how do you integrate evidence-generating research with evidence-based practice? Now, you also need to model both of these things. So establish a culture of doing evidence-based practice where many patients raising questions and issues that come up, you are curious and you assemble the best finds into a library that you can rapidly access for your clinical practice. And you can work on best ways to share the evidence with patients so there's shared decision-making. So that's not just giving the patient a % reduction in mortality risk, it's actually explaining what that means so sense-making occurs, and then the patient can make an informed decision about what they want to do. So in summary, physicians' uptake of evidence-based practice to strengthen and refresh clinical reasoning remains poor despite progresses in resources that can help them. Medical education is now putting a greater focus on these things, and methods to teach medical students are strengthening slowly, but more and more publications are coming out. I've done a bit of a scoping review on that separately, and so I think now we actually have more resources to use. And finally, physicians who have these competencies could be a significant help towards healthcare resilience. So I've finished the presentation there. So if we can, I can take questions.
So, Dr. Jones, I think that a lot of medical schools now are looking at their pedagogical approach to medical education. And critical thinking is certainly a part that they are stressing, many are stressing. How do you see the pedagogical change generally in medical schools affecting this desired outcome?
Well, I think that's what's really, happening is that people are now starting to take a more serious look about what is it that we actually need to teach. It's not enough to just have the student do a research paper and then learn how to practice medicine separate from that, have these twin tracks, and then just simply expect the student to integrate things and come out really being capable of doing EBP. So what we need to do is train the students around the 5 curriculum steps that are in the Sicily document. And so, we do need to keep clear the difference between critical thinking, cognitive errors, and other terms that we could use, as well as clinical reasoning, and then evidence-based or influenced practice. So I do think we need more conceptual clarity. And then, as I said, we need a programmed approach for the entire school through the years so that we have a coherent teaching strategy. So I think at this point, we're not seeing that as fully as I'm describing. And I think that we're going to see that probably in the next 10 years because some of the accreditation bodies may start asking for this.
Thank you so much, Dr. Jones. Very enlightening. Much appreciated.
Okay, thank you very much. Have a good day, everybody.
Okay, and so we are going to move on to our final presentation for this session. Our second keynote speaker should be well known to many of us, Dr. Carissa Etienne. Dr. Carissa Etienne is the director of the Pan American Health Organization, a post she has held since 2013, having been re-elected for a second 5-year term in 2017. From 2008 to 2012, Dr. Etienne served as Assistant Director General for Health Systems and Services at the World Health Organization in Geneva, Switzerland. Prior to that, as Assistant Director of PAHO from 2003 to 2008, where she led 5 technical areas: health systems and services, technology, healthcare and research, health surveillance and disease management, family and community health, and sustainable development and environmental health. A native of Dominica, Dr. Etienne received her medical degree, Bachelor of Medicine and Bachelor of Surgery, from the University of the West Indies, Jamaica, and her Master's of Science degree in Community Health in Developing Countries from the London School of Hygiene and Tropical Medicine, University of London. She is extremely qualified to deliver our next topic, building resilience through transformation of health systems. Please, Dr. Etienne.
Colleagues, a very good day to you. Let me thank you for extending an invitation to me to address this important forum. These indeed have been busy times for public health, for member states of the Pan American Health Organization, including the Caribbean, and of course for me as director of this wonderful organization. We have been working full out to address the needs of millions of people in the Americas that have been impacted by COVID-19 through illness, death, and economic hardships. We have been working under emergency provisions, reacting to the ever-changing trends in transmission, to the urgent needs in scaling up response, while supporting countries in maintaining essential and routine health service delivery. In addition, and as you may well know, I am coming to the end of my tenure as director of PAHO after 10 amazing years. As I reflect back over these years, and indeed over the time that I spent at WHO as the Assistant Director General for Health Systems, I know one thing to be true. The hands-on experience that I gained working in primary healthcare and in the Ministry of Health in Dominica laid the foundation for all that followed. It shaped me and my work, my vision of health as central to the economic and social development, and it guided me in working through the many and diverse set of challenges that we have faced in recent decades. Taking time for reflection is important, even as health emergencies press us to focus on addressing immediate needs. It is through reflection and introspection that we can look objectively at where we are. And amongst the din of compelling and competing needs and urgent tasks, to weave a way forward, seeking clarity of objective and purpose. It is through such reflection that I choose to address you today on an issue of critical importance for the future of the Americas and in particular the Caribbean. We must begin to contemplate health and well-being in a holistic context of sustainable development, well beyond the narrow window of disease and personalized care, important as these are. So the question is this: are the structures, policies, mechanisms, and processes that we have in place supporting the creation of more resilient and inclusive societies, so that we can achieve the aspirations that we have set out in the Sustainable Development Agenda, which includes health and well-being for all as an essential input, as an efficacious outcome, and as an indicator of progress. And given the short window of opportunity that we have prior to the next pandemic, are we really focusing on what we should be doing to make sure that our health systems and societies are truly prepared and resilient? The linkages between social development objectives, health, and the economy and social protection are important. The COVID-19 pandemic has resulted in terrible loss of life, disproportionately impacted the poor and those with underlying health conditions, and devastating lives and livelihoods as a consequence of its effect on economic activity. Weak health system responses, chronic and long-standing underinvestment, and inadequate policies to tackle the root causes of inequitable access to needed health and social services have exacerbated the problem. Most affected have been those living in conditions of vulnerability. In addition, this pandemic has confirmed the precarious relationship and interdependence of health and the economy in the context of a disease outbreak. The impact on economies and sustainable development is evident, with COVID-19 uncovering the structural deficiencies and inequities in access to health services and social protection. The region of the Americas, similar to the rest of the world, is already experiencing a deepening economic crisis caused by the COVID-19 pandemic. The most recent evidence has indicated that we experienced significant declines in GDP in the order of some 9.4% for Latin America and the Caribbean during the first year of the pandemic. And despite some recovery in 2021, 2022 has been characterized by uncontrollable levels of inflation and fiscal crisis, which are were exacerbated by war in Europe and a continuing lack of trust in democratic processes and institutions globally. The region of the Americas, therefore, is facing unprecedented challenges in fiscal, monetary, and social protection policy, intensifying the inequities that already were present in the region. As the Americas persistently remains one of the most impacted regions globally by COVID-19, and one of the most inequitable in terms of income distribution and access to health, this pandemic has laid bare and deepened the pre-existing fault lines and exposed the inextricable interdependence between health, well-being, and the economy. It is important to note that a healthy economy cannot exist without healthy people, and the health and well-being of people depend on an inclusive, sustainable economy and social development policies that benefit all within society. As we begin to realize that the impact of this health crisis may remain for some time, there is growing consensus on the need to critically look at the future in terms of health, social, and economic policy. Fundamental changes are required in how we approach health and development objectives on the basic principle of the guarantee of rights, protections, and access to health, so that people and societies can be protected and survive in the face of multifaceted threats and risks, biological, natural, or economic in nature. The capacity to respond globally to a pandemic depends on health governance and the ability of health systems to respond at the national and local levels in a coordinated manner. Fragmented, segmented, and poorly organized and financed health systems that do not meet the needs of its people under normal circumstances will not have the capacity to respond to people's needs in the face of major public health emergencies. And this ability to deliver well-organized, reliable, quality service to all in normal times, with the added capacity to prepare and rapidly adapt and respond to the threat at hand, are the attributes of a resilient health system. The broader impact of a pandemic or similar threat on a society and the economy depends on the confidence of its people in the actions taken by their government. It depends on the balance in values and policies promoting health, well-being, and wealth generation. And it depends on the willingness of society for collective action to pool resources and risk while protecting its population, especially the most vulnerable. And these are further attributes of a resilient and cohesive society. It was the Caribbean heads of states that declared in the Nassau Declaration of 2001 that the health of the region is the wealth of the region. And I say, how visionary. The Sustainable Development Goals 2030, adopted by countries in 2016, is an expression of political commitment to build resilient, sustainable, and inclusive societies that focus on the elimination of poverty while adopting hand-in-hand strategies to promote health, education, economic development, and well-being. While recognizing progress, however, actions in many countries have largely been timid, with glaring gaps in policy and action being exposed by COVID-19. Policies favoring economic growth are predominantly prioritized region-wide, with social development and health policies being relegated as second tier. The imbalance between economic, health, and social policy contributes to the persistent poverty and inequities in the region.
At the same time, fiscal priority for health and public expenditures in health have been persistently low, with investments in health systems, public health, and the social determinants of health being insufficient to address the needs of the population. While social protection mechanisms have had some success in alleviating poverty and improving health, action has not been sustained, producing mixed results. As COVID continues to decline, countries in the Americas are now being required to envision a post-COVID-19 development era that prioritizes, builds, and embeds resilience within societies and health systems within the context of the SDGs. The resilience of health systems and societies in the mid to long term will depend in part on the country's capacity to address three strategic areas. Firstly, the realignment of core values, rebalancing societal core values in favor of health, social cohesiveness, and development with inclusive and sustainable economic development. Secondly, the prioritization and investment in health, social development, and protection. And finally, the transformation and investment in health systems to ensure preparedness in the face of external threats, while at the same time ensuring universal access to health and universal health coverage. The foundations for action in each of the above strategic areas already exist. COVID-19 has made clear the intrinsic interdependency between health, social protection, and the economy within a society, and the urgent need for structural transformation to achieve the objectives of the Sustainable Development Agenda. Structural and transformative actions will, however, require strong political leadership and significant investments to affect change. Given what we have witnessed over the past 2.5 years, I believe that 5 additional key actions are needed if the path we take to sustainable development is to improve the health and living conditions of all people in a holistic and equitable manner. We must elevate health as a human security, economic, and social development issue. And this also requires leadership and stewardship of the executive branch of government and coordination with all relevant sectors. Elevating the health portfolio within government will permit countries to more rapidly advance in achieving resilient societies and health systems, ensuring universal health while protecting and promoting public health. The decision to elevate health and social development within government on par with economic and foreign affairs portfolios will also have a direct impact on health security and will support countries in improving policy development and implementation with a more balanced allocation of limited resources in the interest of a more inclusive, equitable society, leaving no one behind. The opportunity now to affect real change is clear, as social participation in public policy implementation and oversight has never been greater. We need to prioritize and strengthen integrated policy development and planning. Health, social development, and the economy must work hand in glove to balance societal core values in access to health and social protection with inclusive economic and sustainable development. COVID-19 has reminded the world that health is a national priority for human development and security, and as such, health policy must therefore become a political priority. The most effective manner in which this can be done is through collective and integrated policy and planning development processes under the direct leadership of the executive and based on evidence. Governance in health through national health authorities must be strengthened through effective coordination mechanisms with other sectors and with increased capacity in the area of international relationships. The private sector has a key role to play here, recognizing its capacity in the provision of health services, the production of goods, and technological innovation. Affording priority to health policy per se and as part of a broader social protection system can significantly contribute to poverty alleviation. We need also to transform health systems to achieve universal health and human security. Prioritizing investment and the transformation of health systems to achieve universal health is central to sustainable development and human security at both the national and global levels. And such action is required to address inequities in access and addressing the needs of the most vulnerable, while ensuring that the health system is prepared to respond to external threats. Strengthening health systems based on primary health care contributes directly to the achievement of universal health and to strengthening their resilience. Priority should be placed on ensuring equitable access to comprehensive health services to respond to the needs of all the population. Barriers to access, fragmentation, and segmentation in health systems must be addressed through coherent policy reform and progressive integration of subsystems. The primary healthcare strategy is central to this action, improving the organization and management of adaptive health services within integrated health networks based on a highly resolutive first level of care with the active engagement and participation of the community. In addition to improving the epidemiological surveillance, diagnostic capacity, and rapid response capability, supportive digital transformation and the application of artificial intelligence is required to improve access, quality, and the capacity of health services to solve problems and to meet the comprehensive health needs of persons, families, and their community. In addition, investing in science, technology, and innovation to ensure equitable access to medicines, vaccines, and other health technologies is critical. Equity in access to quality, affordable medicines, vaccines, diagnostics, and other health technologies remains one of the central pillars of a health system. The COVID-19 pandemic has revealed important vulnerabilities in the global research and development framework for essential public health supplies, as well as structural deficiencies in the global supply chain. Latin America and the Caribbean remain highly dependent on innovation and production in a small and concentrated number of countries globally, impacting the access to supplies during a pandemic. Collaboration across countries is required to ensure access and pooling of knowledge and data during a global health crisis to rapidly increase the availability of medicines, vaccines, and health technologies for all. Global action and cooperation remain a priority to ensure that equity in the allocation of limited resources is possible for developing country needs. The Pan-American Health Organization's revolving fund mechanisms for the procurement of vaccines and other strategic public health supplies are regional public goods in this regard. National action, however, is required to update pharmaceutical policy and strengthen supply chain management and the regulatory capacity for medicines, vaccines, and other health technologies. And finally, we must strengthen essential public health functions and national capacity in risk reduction and mitigation. To ensure that foundations in public health and preparedness are strong, and that a nation is prepared in the event of multifaceted threats to human security, strengthening the implementation of the essential public health functions and the international health regulations is necessary. Capacities in public health management, in risk reduction and mitigation require strengthening across the Americas and the Caribbean to protect the health and well-being of all, and to ensure improved preparedness for the rapid mitigation of threats. National capacity is required to improve preparedness and to reduce the risk in the event of the emergence of new pathogens in humans, such as SARS-CoV-2, pathogens becoming more dangerous to mankind, such as antimicrobial resistance, and thirdly, environmental risk factors, including those related to climate change, and finally, other man-made disasters and natural disasters. Ladies and gentlemen, in concluding, we must acknowledge that the post-COVID-19 era cannot be characterized by a return to business as usual. The fissures exposed in the capacity of countries to respond to this pandemic and to deal with future disease outbreaks and emergencies and their catastrophic impact on health, social protection, and the economy require leaders to renew their thinking and to establish a new social contract at the national level and across multiple sectors. And it behoves us all to call countries to task, to undertake a more profound, structural, and sustained transformation to address the underlying causes that impact the capacity to weather the direct and indirect effects of different disasters and emergencies, including climate change. The vision, strategies, and actions that I have outlined for you today are not that new. They are based on those adopted in different international agreements, frameworks, and mandates of international agencies crossing multiple sectors. What is different here, however, is the full realization that our interest in health, social, human, and economic development do not have to compete against one another, nor destroy the environment or exacerbate climate change. They can, however, coalesce around one another to move the region forward in the development of resilient, sustainable, and inclusive societies and health systems in the Americas and in the interest of sustainable development. If COVID-19 has shown us anything, it is that the protection and well-being of human life and meeting the needs of those living in conditions of vulnerability are prerequisites to a future of sustainable development in the Americas. Let me thank you for listening, and I hope you have a very good conference.
Are there any questions? Please, by showing your hands.
Just wanted to thank Dr. Etienne for agreeing to come in to speak to us at the conference, and all her thought-provoking and inspiring words. Just like to extend a personal thank you, Dr. Etienne, and I knew you did this at very short notice, and thank you again.
Thank you for that comment. Any other comments or questions? There is a comment in the chat from Dr. LaVille. Excellent presentation. Thank you, Dr. Etienne. So, Dr. Etienne, from your vantage point, is there sufficient collaboration at this point in the Caribbean, given the challenges that we have?
Well, there is collaboration at various levels. I sometimes attend meetings of the heads of governments of the Caribbean. I would think that there needs to be and also meetings of the ministers of health, of course. And we see a certain level of nationalism that is also creeping into the Caribbean. However, during the COVID-19, the height of the pandemic, we saw Caribbean leaders coming together to formulate approaches, to look for solutions to many of the problems that confronted them, and they did that very well as a region. Clearly, without this level of coordination, no one country will be able to achieve this level of resilience that would lead to sustainable development. So for our region, particularly the Caribbean region, this level solidarity is going to be key. Solidarity, coordination of action, and is going to be very key in us being able to develop resilience and to build stronger economies. And I think that was the whole idea behind CARICOM. But as we all know, as Caribbean nationals, that CARICOM has waxed and waned in its ability to be effective. And we need to recover that leadership within CARICOM to move us to greater resilience, lead us to better positioning in the global community, so that we can truly meet the needs of the people of the Caribbean.
Thank you so much. And in the chat, we have a comment from Dr. Caroline Burnett-Garraway, who is our Medical Chief of Staff at PMH. We are honored to have the Director of PAHO present at our research day. Thanks, Dr. Etienne. And I certainly echo that. We are certainly indeed privileged to have you here with us this morning.
I just wanted to add, though, if we went back to Professor Glenn Jones's first presentation, I think that we can see the alignment and many of the ideas that he put forth in his presentation, how it was also managed in my presentation in a much more policy context. So I think those were really very comparable.
Thank you so much. And so we really appreciate it. And that brings us to the end of this session for this morning. And thank you and good morning.